let's address repeated pregnancy loss, another thing which is in our practice. I love taking this talk actually because in spite of attending so many meetings where a lot of panel discussion on repeated pregnancy loss are there, but we'll end up discussing a lot of non-evidence based protocols. So here I'm trying my best to present how we should look into RPL in today's era. What is the most evidence-based approach for managing repeated pregnancy loss? And that's the question, because you're going to ask, people are going to ask you questions like, should I do IVF for RPL? What is the role of PGTA in RPL? Or how do we manage an unexplained RPL further? So we try and look from the evidence-based manner how we should investigate a case of RPL and go ahead. Obviously, there is a huge amount of evolution and a huge amount of heterogeneity in the data which is presented and how these guidelines have come to certain conclusions. And 2017, ASHRAE talked of more than 3 consecutive. RCOG has always talked of more than 3 consecutive losses, but then beyond 2 losses, everybody starts investigating. And in 2022, equal to or more than 2 losses, consecutive or non-consecutive, were included. And in ASHRAE guidelines, if you look at what has evolved in 2017, karyotyping of both parents and POC was recommended, while 2022 guidelines said parental genetics only if POC has an unbalanced structural abnormality. So very specifics are there. And in India, I feel so sad, very sad, that we still have gynecologists doing torch reporting. We still have people who are doing karyotyping, a routine karyotype, not even microarray for parents. Or they will do microarray of parents without knowing, not having a single report of microarray of the POC. So really don't know what that microarray is doing. So it is more of like karke lo, ye test bhi karke lo kind of attitude. But I think that's not a right attitude to investigate these patients, because these patients are pretty serious and very focused on getting a healthy pregnancy. And we should not be increasing their agony, but evolving them into a particular format of management. So let's talk of some appraisal of these RPL guidelines which are published. Total about 77 recommendations are there, and out of them 62 are evidence-based medicine recommendation, and 19 to 20% are about moderate quality, 55% low quality, and very low quality is 25%. So there is no great evidence published on patients of RPL. No very superior trials are existing as per today. Most guidelines are of published data, and in the published data, not all ethnic groups are included. Like even in India, we have such different ethnicities, so not all groups are included there. So real-time amendments in guidelines as studies get published is not possible. Nobody is doing that. They will publish guidelines every 4 or 5 years. Like 24, yesterday we discussed the hypothyroid guideline, but that only applicable to patients of TSH reports for infertility patients. That doesn't apply for RPL. So immediately they should have published something on RPL. So online, as the evidence gets published, amendments in guidelines should be there. The grit is ability to respond successfully to unpredictable situations, and that doesn't happen with the guidelines, and neither does it happen in our own situation in the day-to-day practice. Second opinion is the most common thing with repeated pregnancy losses, isn't it? People jump doctors. They feel as if the loss was because of the doctor's treatment, and they jump for a second opinion. And second opinion means you look for lacunae in the first opinion, which investigation is pending, and you feel completing that this investigation. Like you'll do thrombophilia if it is not done just because apply is done, or thrombophilia is pending. So we'll complete thrombophilia also. Things like that. So that just does a lot of extensive investigations, and treatments without scientific rationale are promoted more and more. So what is the typical Indian scenario? We do have thrombophilia in our community. We do have hyperhomocystinemia and a metabolic syndrome. All these 3 things they coexist in many situations in our community, and individually each one of them is responsible for a pregnancy loss. If they coexist, definitely it is there. But something, the thrombophilia is not to be investigated as per 2022 ASHRAE guidelines. And time and again, if you ask me, suppose we investigate protein C, protein S activity, and your APLA syndrome, commonly we do see protein S deficiencies in our community. So if we stop investigating thrombophilia, I don't know how much that guideline has relevance to Indian. Again, there is a role of IFS, FOXY to have our own published data or at least have a data collection of complete set of investigation and find out how many patients are actually suffering from problems. Hyperhomocystinemia, which is very high in urban vegetarians. Urban vegetarians, I think the highest are in India. So all your Jain Gujarati communities and a lot of vegetarian community exists in India, and they would have vitamin B12 deficiency. Hyperhomocystinemia is common. So to say that hyperhomocystinemia is not to be investigated, not to be treated, and not a relevant thing in RPL, again, will be a mistake when it comes to an Indian scenario. And such strict vegetarian population is not there, right? From childhood, a strict vegetarian population doesn't exist abroad. The first thing American mother will feed his babies an egg or egg yolk or chicken soup or a piece of chicken, minced chicken. That's the commonest thing which is fed. We go to Africa, the beef would be the commonest thing fed there. Vegetarian comes the last, where in India it's potato and bananas which we feed. ESHRE guidelines said do investigate for APLA and thrombophilia in 2017, and 2022 it says no need for thrombophilia testing. So it says don't do protein S, protein C. But I looked at some Indian data on that. So this is a data published from a hematology department. It is not obstetric department. So there's a tertiary care center. They have published this data who was getting references for patients with women suffering from thrombophilia. Being a hematology clinic, they would have it. And they reported 70.4% had thrombophilia in the women landing up to them. But this is a skewed data because it's a hematology clinic data. That may not apply to our clinics. But still, that does mean that we do have a reasonable amount of women suffering from thrombophilia. So we cannot accept the ESHRE guideline. Don't investigate thrombophilia in the Indian scenario. What about progesterone supplementation? The guideline in 2017 said it's a weak recommendation for progesterone supplement, and there comes the PRISM trial, and they said vaginal progesterone 400 milligram twice a day for women with threatened abortion after 3 losses is worth it. That is worth it, and says that this is recommended after unexplained pregnancy losses. But this is not a big question in India. We use progesterone left, right, and center. Probably the dufaston and dydrogesterone must be having the highest number of brands and highest sale in India than anything else. Today it has become so bad that for a natural 25-year-old lady getting pregnant after 6 months of marriage, you still put her on dufaston. I don't know why. So it has become a consensus to put everybody on dydrogesterone in India. That's a sad part. So ESHRE guideline 2022, there is insufficient evidence to recommend the use of progesterone to improve birth rate in women with RPL in luteal phase insufficiencies. This one. And 2024, oral dydrogesterone was found to be effective in reducing incidence of miscarriages. And oral dydrogesterone can be considered in women RPL as shown beneficial effects in increasing the live birth rate and improving pregnancy. So it has come into as a prevention strategy for patients who have suffered from RPL. So there are obviously some gaps in RPL research and male evaluation. We don't do male evaluations for RPL, but for DNA fragmentation. Again, a lot of us will do DNA fragmentation tests by SCD, sperm chromatin dispersion method, which is the weakest method for doing a DNA fragmentation testing. We should be using a tunnel assay, not COMET, but tunnel assay, flow cytometry, but very few of us will resort to that method. You can do a genetic testing like macroarrays, sperm DNA fragmentation. Further understanding of male contribution to RPL is hardly anything. We don't understand much on that. What about tender loving care? We always said unexplained pregnancy losses, tender loving care. A lot of Australian papers came up saying that, and they even structured the tender loving care. There should be frequency of visits, CBT, talk therapies, showing them ultrasound pictures, etc., etc. But it is not even mentioned in the ESHRE guidelines summary. That is so sad. But we understand our RPL population the emotional burden is very, very high. And to tackle that emotional burden, a structured psychological care, which is a part and parcel, or integrated care with your clinic is a must. So if a guideline is not telling you, as a doctor, we should be putting up a very structured emotional support. How do we do it in our clinics? I say, well, just because you are 3 abortions or 4 abortions doesn't mean I'm going to tell you that you will never achieve a pregnancy. I say you'll always achieve a pregnancy. And what is the new thing? The new pregnancy itself is a new thing. You may not do anything for that. A new pregnancy is a new embryo. As 2 brothers and 2 sisters are different, every embryo is different. Every embryo will initiate its own HLA interaction with the. So embryo endometrial crosstalk initiated by every embryo is going to be different, and you are going to achieve your pregnancies. So I always tell them it's like a toss of a coin. You say heads, 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 and you get tails for 3 times, and then you get frustrated. But there is still 50% chance on the fourth toss you'll get hits. So that is exactly what it applies to an IVF failure as well as a repeated pregnancy loss. But again, the guidelines are not giving how to follow up RPL patient. Should you call them every 2 months? Should you be doing follicular sonographies? Should you be calling them to know their burden of stress? Or you should be doing something? What kind of follow-up? We just say, okay, you get pregnant, come back to us. What is to be given before that pregnancy? There is quite a bit of data published on, obviously, vitamin D, vitamin B12 supplements as it comes to India. Also HCQS, there is quite a few data published on HCQS to be given as a preventive strategy. Also Ecosprin, if you have an APLA positive, you can give Ecosprin before you achieve a pregnancy. But how a structured follow-up should be done is not mentioned in any of the guidelines. There could be two scenarios. A few doctors will over-investigate RPL. And it will be like we are offering more care. It's a very thin line between more care offered and unnecessary cost burden increase. And there will be regional personal variations would be there. See, at the end of investigation, you made them couple spend about 50,000-60,000 rupees. You say, well, I don't see any reason in you. And you're not taken their permission that, or they have not told them that I will investigate, you'll end up spending so much money. At the end, there's a 30-40% chance that I will tell you that no reason exists. And you have to accept it. And you have to regain that strength to have one more attempt at pregnancy. Would you like to go that way? Or would you like to just attempt a pregnancy next time and then look into it further? So you'll have couples taking for either side will be there. Methodology to implement the guideline is also not mentioned. Should you do all the investigation in one shot or should you do graded investigations? That is not mentioned. Okay, and how to audit the methods to evaluate the results? It's just left to the individual clinic. So we have some fallacies. Guidelines do exist, but how many of you, like when the client comes to us, we always tell them, well, you are a case of RPL, and we use ASHRAE so-and-so guideline to investigate RPL. So I write that ASHRAE word there. So I tell them, please Google this word, and you're going to get these guidelines, and cross-check whether I'm evaluating you as per the guideline. And then we take it out. Then we said, this is going to increase your cost burden, so let's do one by one, and we sort out our investigations and take it further. And before investigating a genetic test, especially, we always tell them, if the genetic test comes abnormal, you will be taken for a donor program. Okay, if it is acceptable to you or no, we don't know about it. So it's not a genetic problem. If it is established, it's not something which is correctable. We'll have to go for a PGTM or a donor gamete program to correct that in the future pregnancy. Many of the couples wouldn't even accept that, neither PGTM or donor gamete, and we keep investigating them for genetic problems one after the other. So identifying discrepancies between clinical practice and evidence-based guideline recurrent pregnancy loss. This is a tool for clinical guidelines. This is a nice paper actually. It's a cross-sectional study of 107 obs-gyn specialists in the university and non-teaching institutes. They did a 3-month survey to know how do they define it, what investigations do they do, and what kind of treatment modalities they apply. About 60% said that they treated antiphospholipid syndrome with aspirin and LMWH next pregnancy, while ASHRAE recommends aspirin prior and LMWH after pregnancy. Nobody was following that ASHRAE guideline as such. And 58% still investigate thrombophilia, and 43%, in spite of ASHRAE saying don't investigate, they still investigate. In India, yes, I would say please investigate thrombophilia. We do have that burden here. And this is just a diagram telling you how many of them really follow ASHRAE guidelines, who follow ASHRAE recommendation, etc. It's a very mixed population. So there is a lot of heterogeneity amongst us. How do we investigate and treat our patients of RPL? And that is such a sad story. Why we can't be under one roof of doing a set of investigations, a set of modalities, and a set of advisors. So there is some standard achieved, and then we can do it further. Ovarian reserve is not routinely recommended in women with RPL. Okay, so they said it is unclear, but I would say I would do it because our patients in front of us are asking for what is my prognosis. And well, ovarian reserve is related, a subgroup of ovarian reserve is related to their RPL prognosis. I hope the slide is there, I'll go through that. So yeah, this is the paper. Look at the high incidence of diminished ovarian reserve Okay, in young, in unexplained recurrent pregnancy losses. I told you yesterday, these patients are getting pregnant very frequently, but they do have low reserve. But in spite of low reserve, they are ovulatory. That's why they achieve their pregnancies. And 67% of unexplained RPL and 48% of them had AMH less than 1 nanogram. So nearly 50% have this. And compared to patients with known cause of RPL, unexplained RPL, more patients with FSH beyond 10. So low ovarian reserve is predominant, but no guideline is mentioning about ovarian reserve to be tested for patients of repeated pregnancy losses. So can anti-Mullerian hormone be a predictor of live birth in patients of RPL? You know, there's a beautiful study. 1,155 RPL patients, 90% of them were unexplained RPL. What they did AMH less than 1 nanogram had less chance of pregnancy than AMH beyond 1. After 6 months of AMH, after 6 months, this is after 6 months, AMH, after 6 months, AMH less than 1 nanogram did not improve pregnancy rate, unlike. So this is the AMH which is less than 1, the pregnancy rate after 6 months is not, there is no plateauing of it. And while AMH beyond 1 consistently has more pregnancy rate even after 6 months. So now you are able to identify a subgroup in spite of being RPL. You say, okay, try for 6 months, otherwise I will intervene. While with a good ovarian, you say, well, you need not have that limitation of months. So we cannot obey passive approach of therapeutic nullism for our RPL patients which are so frustrated, so focused on receiving some treatment. Like the husband will say, do what you want, doctor, but I want the next pregnancy to continue well. And we can't say, well, just take folic acid. We can't achieve that. No, that's very difficult to assimilate that. And that also makes the client jump clinics more often. So we should identify a subgroup of RPL who need expectant management and those who need expedited treatments. So we need to do that up. And adding AMH testing to a workup shall offer a more better counseling for at least unexplained RPL. A subgroup you'll be able to counsel them more objectively. Definition, defining the loss is so difficult, you know. It could be a biochemical loss, it is a visualized pregnancy loss, or intrauterine loss after your heartbeat appears or before that. So all these should be part and parcel of one definition only. It is to be considered as abortion, even it is a chemical pregnancy. Don't consider it as a separate thing. We'll come to that, why I'm saying so. So how do we define losses as per the guidelines? ASRM says do sonography and a histopath of chorionic tissue. ASHRAE only intrauterine to be included, but molar and ectopics to be excluded. But even those cause the same frustration, same depression, and associated with the same agony to the couple and to the doctor as well. But they say don't include it. But we would love that to be a part of our evaluation. ASHRAE says non-consecutive losses, ASRM, RCOG only consecutive losses. But the trouble with the couple is the same. So I think we should have non-consecutive losses as part and parcel of our definition. This is one beautiful paper actually. Non-visualized pregnancy losses are prognostically important for unexplained recurrence. Isn't it common? Like we see patients coming, 2-time UPT came positive, both the time it did not continue. I had menses after 5-6 days. I wanted to took an ultrasound appointment. I had menses before that. And then you are perplexed. Are you going to investigate as per RPL, or you're just going to say, don't worry, one of them will continue very well? The client wants investigations. He says, there is something wrong with me. Why I'm getting repeated chemical pregnancy losses? Okay. From that point, this paper is so very beautiful. So there are about 918 women of Danish repeated recurrent miscarriage clinic from 2000 to 2011. I don't know when we are going to get such studies in FOXI and ISAR and IFS. We are not even having a uniform data reporting system. Why can't we have HFEA, I feel, not to audit, just to report. Let them not take any action, whether you get pregnancy or don't get pregnancy, but at least start reporting. So we'll come to know what's our problem, Indian problems. We're just hiding away from the truthful audit. We do our audit at Sunanda IVF, I must say. We do it at Jahangir also. We have an external auditor. And how I came across Professor Gerard Conway was a goodie also for that matter, because I wanted these people to audit myself. of whether we are doing correct. So I used to have an external auditor for my embryology lab also called Hasmukh Bhai. Unfortunately, we lost him 2-3 years back. But that guy was great. Every year he will come with me, sit in our laboratory for 15 days, evaluate our procedures. He's the one who standardized our laboratories more and more. I think all of us, we should not be riding a horse saying that we are successful. We need to audit ourselves. We need to have an external auditor place, because that's the only way to improvise in your system. If you don't have an external auditor, it becomes very difficult. I had that experience with Ethiopia. Ethiopia, it was an established IVF unit for 2 years before we went there. They just requested us saying that, well, we are not getting good amount of results. We are facing more failures. Can you look into it? And me and Sharif, we started visiting that. And we looked into every detail of the clinic, right from their processes, their embryo transfer techniques, their embryology techniques. We called their embryologists to us. We evaluated them, their protocols, everything we kept on altering. And now we need not go there because they have achieved a steady pregnancy rate over a period of time. So putting an auditor makes a huge amount of difference. So, they put into 3 categories: USG diagnosed pregnancy losses, failed pregnancy of unknown location, only HCG positive on USG positive, USG performed but pregnancy not seen. So pregnancy at unknown location, and biochemical loss, just HCG positive and no USG done. And these are the 3 kinds of classification they did over a 10-year period of patients of recurrent miscarriages. And they reported about 2,454 pregnancy losses, 23% biochemical, 16 failed PUL, and 58% clinical miscarriages. So the load of biochemical losses is 1/4. It's quite a bit. So then they evaluated them, and they called RPL that more than 2 losses. The odds ratios of live birth in the next pregnancy was 0.89. So the forest plot is on the negative side. So the moment you have more than 2 losses, your chance of getting a next pregnancy is on a negative roll, even if it are non-visualized pregnancy losses. So only that you have 2 clinical losses, that's your chance of again a pregnancy loss in third is high. That's accepted. But even if you have 2 biochemical losses, your chance of pregnancy loss in the third is high. The odds ratios are suggesting that. An odds ratio of 0.82 for clinical pregnancy losses. There's no difference. Having 2 clinical pregnancy losses, the chance of third loss is high. Even if you have 2 biochemical losses, chance of third loss is high. Then why not implement investigations for even biochemical pregnancy losses? The guidelines don't say a word on these things. So non-visualized pregnancy losses are like clinical abortions. They have a similar effect on the live birth rate. Odds ratios are the same. With each non-visualized pregnancy loss decreases a relative risk for live birth by about 10%. It is very significant. So do investigate your non-visualized pregnancy losses as if you are investigating a case of RPL. Genetic analysis. What about genetic analysis? Of pregnancy tissue following pregnancy loss is not routinely recommended, but it could be performed for explanatory purposes. बराबर है ना? Routine करेंगे तो आएगा तो what are you going to say about it? Just for to know the reason. You say, well, you had a Turner mosaic or a Turner pregnancy, that's why you aborted. So there's no need to do further tests, only for explanation. You're not going to take any measure in the next pregnancy whatsoever. And for genetic analysis of pregnancy tissue following pregnancy loss, array CGS was recommended. So, and that also evolved. It evolved from karyotyping to FISH to array CGS, and now we do microarray NGS studies. So the whole genetic technology also evolved. So what we are picking up is also a different story. Every 4 years, the story has kept changing. So what should we follow when it comes to genetic losses? And this is a very, very important thing. So chromosomal microarray is advocated. So unlike standard karyotype, 24 chromosome microarray analysis does not require a viable tissue, does not require cell culture, and thus reducing test failure rates often seen with traditional methods. What if you do a karyotyping? It says, well, we could not culture the cell well, DNA was not well recovered in FISH, etc., while chromosomal microarray is going to bypass all that thing. So if you want to recommend anything, please do not recommend karyotyping, routine karyotyping for POCs. Please do not recommend, only recommend a microarray testing. So this is a beautiful paper. I love this paper actually. And this is a recent publication. And recurrent pregnancy loss evaluation combined with 24 chromosome microarray miscarriage, What he did was, in every pregnancy loss, they did a 24 chromosome microarray of the miscarriage tissue. And look at the unexplained pregnancy losses, less than 10%. Then why not adopt this policy in our practice? Why not do microarray for every pregnancy loss? Why not be proactively telling the couple that if you don't do a microarray of POC, well, there's 50% chance that I'm not going to come to any conclusion why you had a loss. But if you do microarray, in most of the cases, I'll be able to come to a conclusion that why you had a loss. So that did that. The first miscarriage, no action taken unless it's clinically indicated. Second miscarriage, obtain the POC, chromosomal microarray, aneuploid, no need to do any further evaluation. You leave the couple. It's just nature's mistake that this time you had an aneuploid pregnancy. For all you know, next time it could be a euploid pregnancy. No further investigation to be done. But no, even these couples will go for torch, etc. Yeah, your answer. Huh? Yeah, they do a maternal cell contamination first. They rule out a maternal cell contamination, then only give the reporting. That's all. होता है वो करके देते हैं वैसा. You are very right actually. Yeah. So if you find unbalanced chromosomal translocation or inversion, then only you perform parental karyotype. If you have aneuploidy, there is no reason to perform parental karyotype also, only if this is there. And if it is a euploid POC, then you are going to do an ASRM or HRA guideline, further RPL workup. So it gives a very clear way at how we are going to put it up. It's our job is to put this across to our clients. Okay? It feels very sad that you go for RPL. I'm being critical, but that is the truth. I recently was in Nashik for a conference, and there was a RPL panel discussion, and they were talking of karyotype kaise karenge, how will you send a sample? I said, gone are the days. We should be doing this kind of a strategy for every POC. And they said they do karyotyping only for indicated patients. Which indications, nobody knows. Then next one. So you are doing ISRM RPL workup and POC, chromosomal microarray. That also after second miscarriage, you can do all these things. Normal, I said marriage. Normal ASRM RPL workup and POC, chromosomal microarray, was seen about 5 out of 10, 5%. Abnormal workup and POC microarray were 95%. So if you do POC microarray in every case and do ASRM all RPL tests, your pickup rate is 95%. Then why not adopt to this strategy rather than missing on the microarray part? So the chromosomes do go very wrong. People ask, what is the importance of teratozoospermia? I said, we don't know whether we are all made up of a spiral tail sperm, or we are made up of a globazospermic sperm, we are made up of some elongator. We don't know that. Nobody knows it. So nature must be doing some mistakes there. And those mistakes or aneuploidies are very common in humans. They are not common in animal kingdom. In animals, you don't see abortions. Animals, we don't see somebody dying of puerperal sepsis. Very rarely one would see. People don't see PPH in animals, isn't it? Or guy died of PPH. Nobody says that. Okay, they don't even have aneuploidic pregnancies. Abnormal guy born hua, a dog with tail here and a head behind somewhere else. ऐसा कोई होता नहीं है. Humans are born in very different fashions. So we have very bad genetic. Nature has not done a justice to us. They have just made us intelligent and left to suffer. Chalo, suffer hona samajh bhi lo, suffer ho rahe ho karke. So it is very sad that humans are not bestowed on these abilities of the other animal kingdom is great. So you understood the pathway, how to investigate an RPL and your biochemical losses also. So this is the controversies in ART. So can an ART laboratory cause a pregnancy loss? And that question will be asked to you by your patients. I had an IVF pregnancy. Did something go wrong in the laboratory that I lost my pregnancy? Well, she's spent about 3 lakh rupees by then, and she's all the right, the couple has to ask you this question. So factors like type of culture media, pH, temperature, osmolarity, oxygen concentration may impact chromosomal separation and segregation that may influence aneuploidy incidence. If meiotic in nature, the problem is meiotic in nature, all cells, all the resulting embryo are impacted, and the focus may be only on the clinic. This will focus more on the clinical practice, clinical decision making. and the stimulation protocols that can impact a meiotic problem. But if it is in mitotic in nature, the division takes place in your laboratory. So the IVF laboratory parameters may be harming that part of the story. Next is, who shall go for PGTA with recurrent miscarriages? This is again an important question. So I must tell you this story. This radiologist was working with me. Unfortunately, she had about 3 abortions, and she was quite hassled. And she was very young, thin girl, regularly ovulating. Even if she tries for 2 months, she'll get pregnant immediately. And she was under severe stress, and we kept her telling her, please don't worry, She was very frail. Just put on a good amount of weight and you should achieve a pregnancy. We were reassuring her. Some YouTuber influence was there, and she landed up in Mumbai. And they was convinced by the YouTuber, you go for IVF with PGTA. Okay, she spent hefty 4.5 lakh rupees on IVF with PGTA to be told at the thawing of the embryo that the embryo did not thaw well. So, did you correct it or did you add to the frustration? You added to the frustration unasked for by the science. Then the whole family came to us. I distinctly remember they came to Pune to meet us. They were from Ahmednagar. By the time she had relocated to Aurangabad or Ahmednagar, the whole family came. We were the same notion. Please wait, nothing will happen. Very 2 months she got pregnant. She delivered a baby also now. So again, I'm telling you, we really have to pick up and choose who will be benefited. Just because they are willing, they are frustrated patients. So they will say, okay, PGTA, you upload embryo? Yes, I'm in. But whether it will make a difference to them, that we have to analyze. So patients with normal ovarian reserve, yes, you can do PGTA because normal ovarian reserve will offer you a lot of eggs to be evaluated. ASRM tests are negative. Previous aneuploid miscarriages and multiple blasts are available. Then only PGTA will work. You have one single blast. Why do PGTA? Might as well transfer if she's young. Might let the nature decide. Because PGTA at a younger age deselects normal embryos. It has been proven beyond doubt now. PGTA only at an older age is useful. Younger age, it deselects a normal embryo. Because that's why we should not be offering PGTA to them. Only a few reasons. So, can we have a prediction model? Okay, I feel it's like tossing a coin. I still find that, and this is a prediction model. But the prediction models will give you a lot of guidance how to do a counseling. And AUC, the discrimination at area under curve 0.7 is a predicting difference between 2 variables. And if you can have a variable which has an AUC of 0.7, that means you can say, well, you can't discriminate on this particular variable. You can say, well, this can happen or not happen. Calibration is agreement between the observed and predicted outcomes. It just tells you the frequency of the problem. And clinical use will be of this discrimination or calibration. So what is the chance of having a live baby is the commonest question asked. The candidate predictors are age, number of losses, BMI, and smoking. But in the data, on the retrospective analysis data, they found they completely missed data because they are not reported APLA, thrombophilia, sperm DNA fragmentation, and treatments used like aspirin, heparin not mentioned. So we can't be having just variable there. We'll have to have variable in the treatment given, everything to be assessed to discriminate or calibrate where a particular problem and how it is related to the pregnancy loss later. So data is very insufficient here. These couples were followed for 1 year. 66% of 526 couples followed had an ongoing pregnancy in 1 year. 34% no ongoing pregnancy, repeat abortion, ectopic pregnancy or MTP and fetal anomaly. So this is one information you can provide them. There's a 2/3 chance your next pregnancy will be good. Don't worry about it. Now I want you to look at this. This is what I added. You look at the Kurasamy trial, which was published on giving progesterone for unexplained pregnancy losses. It was a multicentric, randomized, prospective trial. What is PROMISE trial? Was it a PROMISE? Manan, tujhe bayar tega wo. PROMISE trial mujhe lagta hai. So they did a trial for 3 unexplained pregnancy losses. In one group they gave progesterone supplement. In another group they did not give anything. So that's a control group. The pregnancy rate in both the groups same. So now you forget the treatment group. Look at the control group. What did they offer? Nothing. And what is the pregnancy rate? 60%. No progesterone given. Live birth rate still more than 60%. So make this a counseling tool. That there is a big trial published. They did not do anything. They just kept on giving tender loving care, reassuring them. 60% of them had live birth rate. Please don't worry. Okay, so look at the control group. It is definitely telling us that we should be giving, and this can be used for a counseling tool. Odds of an ongoing pregnancy after 3 losses were 19% less than that after 2 losses, while after 6 losses, it was 47% less. Maternal paternal age, BMI had a linear relationship with decreasing ongoing pregnancy. And so we need to look at the couple's predictive factors, not just the ladies. So we look at, take husband into consideration, his age. If his age is beyond 45, if he is very obese, he has a bad metabolic syndrome, then, well, his sperm DNA fragmentation problems are going to be high. Even that needs to be controlled. Maternal BMI and the risk of miscarriage. When you have a low BMI, you still have a very high risk of miscarriage. And that's a very typical Indian population. Okay, the coastal, I was doing a survey, we are doing a study on polycystic ovary syndrome phenotyping in India, and we used to go in Konkan belt looking at the girls. They eat only rice. The only carbohydrate is rice. The chapati or bhakri is not the part and parcel of their diet. The chapati is prepared only on festival days. So they have a single carbohydrate, all skinny, thin girls. BMI would be 15 and 16. And when I took that data, I remember my talk with Siladitya Bhattacharya. The first, he looked at the data and he said, no, Sachin, you are misdiagnosing polycystic ovary. These are hypothalamic amenorrheas. For a Western population, very difficult to accept a very thin, lean PCO ever exists. Recently, last 1 decade, they have started accepting this thin, lean PCOS. Otherwise, PCOS means fat lady in Western population. Okay, so very low BMI will also have a high miscarriage. And you know, the girl in front of us is 36 kg and we are rating Apla syndrome and thrombophilia. Don't talk a word to them about diet and improving their weight. That's a sad part. So this is one factor which exists in India. We need to look into that part. Recurrent pregnancy loss, couples' perspectives on their need for treatment, support and follow-up. I love reading such kinds of papers which talk of regret of treatments and things like that. And you know, that gives you real information on how to counsel your patients. RPL is couple issue, both partners, but most research does not involve both partners. You just evaluate the lady after lady. But husband is equally frustrated. Husband is equally saddened. But we don't look into his part at all. What do they need as a couple chasing next pregnancy is something which you need to advise. So how they can have cohesiveness, bonding, trust each other, not to have a blame game. This can be corrected, has to be educated to the couple as such. Something must be wrong is a growing fear, and will they ever become parents? You know, well, my vansh will end today after these 3 losses is the biggest problem they face. And nobody is answering that particular question. They are speaking to their relatives, but they can't ask this question to their relatives. Because relatives are also thinking on the same line. So as a doctor, you have to be proactive answering them. You don't worry, you will definitely have babies in future. That positive counseling is a must. Sense of exhaustion from grief, pressure, and again to start all over. You know, the problem is, after 2 months she loses her pregnancy. Oh, again we have to start all over. With timed intercourse, diet and folic acid, etc. Again, the whole story has to restart. That's very frustrating. Can we bear one more loss? That's another thing. They say, I've seen couples saying, ligate me up. I don't want many more pregnancies. I'm sure you must have faced these couples as well. And husbands need to be positive, encouraging the wife in spite of deep sense of loss. So you have to take your husband aside and tell him, well, we agree with your loss, everything, but the only person who can support her is you. Because you need to be cohesive. Because if you don't support her, then the whole thing is problematic emotionally. The couple says we need answers now. Why wait? Need a formal follow-up plan to reach a successful future pregnancy. And the guideline is not giving a follow-up plan only to you. And the couple in front of us definitely. So how should we manage before we go to the next pregnancy? The guideline is not telling anything to you. No structural follow-up in the guidelines. Please don't make us go through a cruel pain of one more loss is a request by the couple. So you need to spend time. So go stick to evidence, stick to science, evaluate and do the positive counseling of that you will be achieving a successful pregnancy. Guidelines, no structural plan to cope up with negativity again. So there is a scope for Foxy and everything. They can come out with guidelines and fill in the gaps in the ASHRAE guidelines. But again, the helicopter is important. So when to conceive again? That is one more question the couple is asking and we have no answer. And everybody that is frenzy. They say, 3 mahina, no pregnancy. But her AMH is 0.5. What are you telling 3 mahina no pregnancy? She will be worsened after that time. So I commonly give them advice not to wait for 1 month and start planning pregnancy the very next month. I never give them a period to wait for the next pregnancies. Thank you so much.